Okay.
Yes, sir. 32-year-old male, Mr. XYZ, residing at Perambur, Chennai, studied up to 11th, who is driver by occupation, belonging to lower socio-economic status.
Yes.
Next slide. Came with the chief complaints of swelling in the right groin for the past 5 months. Next
Yes.
slide.
Here I want to tell, in presenting complaints, as we have already discussed, you will always put the presenting complaints in patient's own words. As Karthi had correctly said, groin would be the layman's term. Okay. Once you move on from presenting complaints to later stage, you can use your medical terms or technical terms like inguinal region, right? Okay. For example, if you are to mention about a thyroid swelling, you should put it in the patient's own words, like swelling in front of the neck. Okay, like that. Yes, you can proceed, ma.
History of presenting complaints. Patient was apparently normal before 5 months, after which he noticed a swelling in the right groin, which is insidious in onset, initially small in size, and gradually progressed to attain the current size. Swelling started in the inguinal region and extended into the scrotum. It is aggravated on coughing, standing, and straining. Relieving factors fully reducible manually by any self. It is not associated with any pain.
Yes, small discussion we'll make here. Go back to that slide. Yes, you said it's a insidious onset swelling in the inguinal region. Okay. So, what are swellings which can be non-insidious? Sudden onset swellings.
Any malignant swellings?
Sudden, eh? What are sudden swellings?
Swelling.
Inflammation. Inflammation also will take a few days to develop, right? So, inguinal region, if a lymph node has to develop, it will take minimum 2 or 3 days. What swelling can appear immediately, within minutes or within a few minutes or hours? This is a general question as well. Yeah, very good. Traumatic hematoma can be instantaneous. Okay. And vascular swellings like ruptured aneurysm, ruptured AV fistula, and such things are instantaneous swellings. All other swellings are insidious. The period of insidiousness varies. Okay. Acute inflammatory swellings like lymphadenitis or an abscess can develop within 2 or 3 days. Malignancy can develop in at a later date, like 2-3 months. It will develop slowly and progress. Okay. Benign swellings like a fibroma or a neurofibroma will take years together, 3 to 4 hours. See, this is called the chronology of a disease. This is a general rule. Instantaneous swellings are either traumatic or vascular. Am I clear? Huh? If they ask you what swelling can develop instantaneously or very sudden onset, it will be post-traumatic hematoma or a ruptured aneurysm or a ruptured AV fistula, right? This chronology you should remember. The benign neoplasms are characterized by their long duration, okay? 4 years, 5 years, 6 years, they will grow very slowly. That is typical chronology of a benign tumor or a benign neoplasm. A malignant neoplasm will have a short duration growth. Like in 3 or 4 months, it will become rapidly grown in size. Okay. Acute inflammatory swellings will gain bigger size or increase in size within few days. 3-4 days before, nothing would have been there. But 3-4 days, it will become big, painful like that. It is an inflammatory. This is a typical knowledge. So here, any swelling in the groin, which is insidious in onset, is a hernia and not likely to be a lymph node or a inflammatory swelling for that matter. Very good. Okay. And the relieving factor, I think you have forgotten one. Can you bring it back? All others are right. it is appearing on coughing, standing, straining. What is the relieving factor? Fully reducible manually by himself. Can it get reduced in another way?
Lying down, sir.
Very good. Spontaneously disappearing on lying down is one of the hallmarks of what Gokul is answering.
Direct hernia.
Direct hernia,
Oh,
sir.
direct.
Direct.
Indirect hernia needs some sort of manipulation from patient's side, or it gets reduced with a bit of efforts. Okay. Typically, a direct hernia will most often, when the patient lies down, it will get reduced spontaneously. So relieving factors means you should tell the swelling does not get reduced spontaneously, but it is reducible fully by manually or by himself. Okay, manually by himself or with some efforts. Right, very good. Not outside of the pain you have wrote. Okay, what are the scenarios where hernia can be painful?
In stagnated cases.
Yes.
Inflamed hernia.
Very good. Apart from inflammation, strangulation, can pain be there at a normal stage, uncomplicated hernia?
Yes, sir. Initially, there will be some dull aching pain before even the swelling has started in that region.
Yes. Okay.
Then the pain will subside and swelling will be arising. Then on getting complicated, the pain may arise again.
Is there a difference between both pains? What is the first pain due to? You said no, before it becomes obvious, the patient dragging pain. Very good, exactly. What is it due to?
Because of the pull of the content downwards.
Pull of the content reflecting on what structure? What is the content?
The spermatic cord in males and
no, it's either intestine or omentum. Okay, I guess.
Pulling of mesentery, sir.
Exactly. So the contents are either bowel or omentum. Mainly. Okay. So when they descend down, they, as our other student has told, it causes a traction on the mesentery. So the mesentery is attached where? Into the posterior abdominal wall, right? So the peritoneum has got a anterior layer and a posterior, which is laminated in the posterior abdominal wall. So when traction occurs, the splanchnic nerves are stretched, and that causes the dragging pain. Okay, so this is one type of pain. To make it clear, in all of the hernias, three types of pain may occur. One is this pain which we have told. In uncomplicated hernia, yes, in uncomplicated hernia, there may be dragging pain to the traction on the mesentery, causing a kinking in the splanchnic nerves in the retroperitoneum. Number one, okay?
Yes.
Second one is a spasmodic pain. Karthika, can you tell where it can occur? Spasmodic pain means it will come intermittently, okay? So it will be there, a spasmodic wave will come. The patient will feel the pain, and once the peristalsis stops, the patient will be free of pain. Again, when the peristalsis stops. Good. So uncomplicated, but obstruction is there, but strangulation has not come there. The spasmodic pain will be there. That is the second type of pain. Third pain is what you have already told me. You can just repeat it. It's a burning pain. Yeah. Burning pain or a pricking pain due to inflammation. The blood supply to the contents is cut off, and the patient is going on to inflammation, okay, infection, sepsis. They will have burning pain. So to put it back, all types of hernia, any type of hernia can develop three sort of pains. One is in uncomplicated hernia, you get dragging type of pain, which is most often felt in the lower abdomen or at the back. It is due to the traction on the mesentery, causing a kinking in the splanchnic nerves in the retroperitoneum. Number one. Number two is complicated hernia where an obstruction will cause spasmodic pain, which will come in waves, which will be felt, relieved. Okay, and it will have somewhat radiation type of pain from lower abdomen to the scrotal part. Number third one is in obviously complicated hernia where the contents are inflamed and the pain will be of burning or licking pain. Am I clear? Very good. Okay. Next.
Next slide.
Yeah.
Next slide. No history of irreducibility, no history of colicky abdominal pain, no history of vomiting, abdominal distension or obstipation, no sudden increase in the size of the hernia, no history of chronic cough, difficulty in micturition or defecation, no history of discoloration of the skin over the swelling, no history of trauma.
Okay. So irreducibility, nothing is there. Okay. Right.
Next slide.
So where will you emphasize this history of difficulty in micturition? In what subset of micturition? Which subset of patients or which group of patients in relation to age you will concentrate?
Due to urinary tract infection.
Is it that? Difficulty in micturition, what is the commonest cause in which age group?
BPH.
Yes. You can text others. If your voices are colliding, you can text it. I'll open the chat box and see. Yes, Gauri has said BPH in older woman. Older man, sorry. Yeah. BPH in males. It should automatically come, Kartika, right?
Yes.
Difficulty in micturition. The commonest cause is benign prostatic hypertrophy in elderly man. So you will specifically ask for such difficulty in micturition in that age group, which should not be left out. The other group, as Kavya has put it in the chat box, is in young persons. Yeah, very small subclinical hernia can become big in the presence of urinary obstruction due to urethral stricture, or in pediatric age group, it might be due to phimosis. Right? Over age group, urinary disturbance வரதுக்கான சில காரணங்கள் உண்டு. Certain etiological factors are there. In children, it is phimosis, balanoposthitis. In a middle age or elderly, in young individuals, it could be urethral stricture, secondary terms, some infections. But in elderly people, it is mainly the benign prostatic hypertrophy. Okay, right? Yes. So, vomiting, abdominal distension, you wrote, okay. Come.
Past history? No.
I'll stop you for a while. I'll stop you for a while and ask you a few questions regarding the. Suppose in your exams, hernia patient age 65 comes with some urinary problems. The other questions will be asked. Okay. Once the patient complains of difficulty in micturition, what are the other related histories you will ask? Or what are the other related symptomatology of benign prostatic hypertrophy?
Any swelling is present.
Where? Symptomatology is the patient's complaints.
The groin region.
No, that's hernia. It's all right. In relation to benign prostatic hypertrophy, what are the other symptoms the patient will give? One is difficulty in passing urine. Other things, some many C's are there, C-wise. When will you suspect BPH? The first complaint would be frequency of urine. Yes, Kavya has told urgency. Yes, one of the complaints. These CYs, many CYs are there. So frequency, increased frequency, especially nocturia is the first one which will be complained by the patient. Okay. So first one is frequency. Next one is urgency. So next one is Kabilan is telling dribbling after urine. That's also correct. I'll tell you the few symptomatologies. CYs you remember. One is frequency. Next one is urgency. Next one is hesitancy. So the patient will first complain, I'm getting to urinate more times, he will tell, number one. And the patient will also tell, I cannot wait to go to restroom, I am in urgent mode. That is called urgency. Okay. But once the patient goes to restroom, he will feel like urinating, but he will not be able to. That is called hesitancy. Okay, this may not be present in all patients, but these are all the things: frequency, urgency, hesitancy. Another thing is called a precipitancy, where the patient, before going to the restroom itself, will pass out some urine and wet his undergarments. That's called precipitancy. Okay, so frequency, urgency, hesitancy, and precipitancy, all these things. And retention overflow, one we call. So once the bladder is full, the patient will automatically, it will overflow and start wetting the undergarments. That's what Kabilan has said, dribbling you can tell. It's not dribbling after urination. Even after passing urine, the patient will, without his knowledge, start to pass few drops of urine. Okay. So kindly remember the symptomatology of benign prostatic hypertrophy. Can you come back, Karthika? Tell me.
It's a frequency,
Yeah.
urgency, hesitancy, and precipitancy.
Yes, and overflow, retention overflow without his knowledge. Okay. Okay. Very good.
Yes.
Right. Past history.
Consistency, no history of similar complaints in the past, no history of diabetic mellitus, hypertension, tuberculosis, asthma, epilepsy, jaundice, ischemic heart disease.
Yes.
No history of previous surgery, no history of drug allergy.
What previous surgery is should be asked in a case of hernia?
Appendicectomy, during which they can damage the ilioinguinal or iliohypogastric nerve during gridiron incision.
You should tell appendicectomy in a right hernia patient. Okay. The patient is having left-sided hernia. There's no point in correlating the two unless the patient has got situs inversus. Okay, wow. So appendicectomy in a patient who is having right-sided inguinal hernia. Right. Yes. There is another thing called a recurrent hernia. That also you should ask. Okay. Same side hernia surgery done due to various reasons, it recurs. That surgery also is very, very important because the management of recurrent hernia is a bit difficult and different from the routine hernial surgery. Okay, ma?
Yes.
Right. So, what is the significance of tuberculosis? Past history you are asking, no?
Yes, it can be an immunocompromised patient if there is presence of tuberculosis, or it can lead to secondary tuberculosis of GI tract.
Is that the reason why you are asking? Yes, John Javi's text says chronic cough and Kavya also says cough. Yes, very good. So, post-tuberculosis, the patient will have a destroyed lung. Okay? There will be fibrosis and partially non-functioning lung. And there will be retention of secretions, which will result in chronic cough. All right? So, you should tell tuberculosis, chronic bronchitis, asthma can be precipitatory factors for emerging hernia. Right? That you should remember. Okay, tuberculosis can be a etiological factor because the patient will cough, and he will strain. That is the reason. Okay, right. Next slide. Yeah.
Okay. Treatment history, not taken any treatment for the current condition,
Yes.
not on any medication for other ailment.
Very good.
Next slide.
Yes.
Family history, no history of similar complaints in the family, no history of connective tissue disorders in the family.
Very good. Okay.
Next slide.
How does smoking influence hernia? Personal coming on to that now.
There can
Okay,
be
okay. Start reading it. We'll ask the question in that context.
a personal history is on non-vegetarian diet, normal bowel and bladder habits. Smoker for past 10 years consumes 1 pack per day, not an alcoholic, a normal sleep pattern.
And this is very important. Smoking relationship, smoking with hernia. Why is it important?
It can lead to collagen disorders.
Very good. So degeneration of connective tissue. Okay, connective tissue degeneration can occur in smoking. Number one. Number two. It can lead to smoking can lead to chronic bronchitis. Yes, COPD and chronic bronchitis. There are many terminologies. Okay, smoking can cause all such respiratory problems, which can be a etiological factor for hernia. Purida, the first one, as I already told, connective tissue weakening leading to tissue weakening and hernia formation. Second one is increased intra-abdominal pressure due to chronic bronchitis in a smoker, which can result in hernia. Number two. Anything else from treatment point of view?
It delays the treatment recovery. It delays the recovery process.
Exactly. The healing is very much delayed or poor in a case of smoker compared to a non-smoker. And post-operatively, smokers are more prone for cough. So post-operative complications are more, and recurrences can occur. Okay, you would have done the surgery very well, nicely, but post-operatively the patient keeps on coughing due to past smoking or smoking, which is which is carried on. Okay, so everything in smoking can have undesirable or negative effects upon hernia. Number one is connective tissue weakening by nicotine in this smoking. Number two is chronic bronchitis being an etiological factor. Third one is post-operative healing is poor or delayed. Fourth one is recurrence is more in a smoker compared to a non-smoker. All these things you will have to remember. Right. Next slide, please.
Yes. Summary: 27-year-old man presented with unilateral reducible swelling in the right groin since 5 months, which is aggravated on walking, coughing, and staining. There is no history suggestive of strangulation or obstruction. For the given complaints, I would like to examine the inguinal spotted region.
Okay. Excellent. Very good. This is how you summarize. I already told you. I will just try to remind you. There are two summarizations which we expect from you. The first summarization is at the end of history taking, which is meant to choose the system which you are examining. That's all. Okay. The second summarization is after completion of your examination. That summarization is meant to give you a provisional diagnosis. Okay. Right. Very good. So, summarizing, you would like to examine the inguinal region for possible herniation. You can tell it for possible. Okay. In other cases, you can say, I would like to examine the abdomen for possible benign gastric outlet obstruction or possible gastric malignancy. Like that, you can tell. System you should mention. That's the purpose of summarizing at this stage. Very good, Ma. Continue.
General examination, patient is conscious, oriented time, place, and person, moderately built and moderately nourished.
Yeah.
No pallor, icterus, no sinuses, no clubbing, no pedal edema, or no generalized
Yes.
lymphadenopathy.
Very good. Next.
Vital signs, pulse rate 68 per minute, regular in rhythm, no specific character, felt equally in all peripheral palpable vessels, no radial delay or no radiofemoral delay. Blood pressure 120 by 80 mm of Hg, measured in right upper limb in the sitting position. Respiratory rate 16 per minute, regular in rhythm and abdominothoracic. Temperature afebrile.
Next slide.
Next
So
slide,
here this purpose of general examination is to assess the performance state of the patient, his general status and his eligibility to go in for surgery, stand the surgery, like that. Okay, anesthetic fitness will be all right. So general examination is meant to evaluate or assess the general condition of the patient for possible future surgery. இதுல என்னென்ன ப்ராப்ளம் இருக்கோ அதெல்லாம் நம்ம you will have to rectify it. So the general examination you will have to see cyanosis. So anemia இருக்க patient கட்டாயம் ஆப்ரேட் பண்ண முடியாது. Anesthetic won't give fitness, right? Like that, if the patient is having extreme tachycardia, like 120 beats per minute, the anesthetist will immediately tell, go and correct it or get cardiologist opinion. Right, ma? So another patient with bilateral pedal edema with hernia, you will have to immediately think of
any cardiovascular.
Yes, any cardiovascular or renal problem, CRF, or acute renal failure. So a surgeon should extend his view apart from his disease, because the patient has to be taken for surgery. It is the duty of the surgeon not only see his disease, but the fitness of the patient as a whole, to make him fit for the surgery and make the surgery a success. Okay, it's not only enough to do a good surgery, but bring out the patient alive and hale and healthy. So general examination, though you are a general surgeon, you should be able to assess the overall performance state of the patient. That is very, very important. Your eyes should catch each and every danger signal. Okay, ma'am. Right.
Local examination, examination of the right inguinal region. Patient is exposed from umbilical region to up to the mid-thigh. The patient in standing position. Inspection, 15 cross 8 centimeter swelling in the right inguinal region, which is pyriform in shape, extending 9 centimeters from anterior superior iliac spine to the bottom of the scrotum. Surface is smooth, the border is well defined.
Okay.
Skin over the swelling appears normal. No redness or dilated veins or scars or sinuses. No visible pulsations and peristalsis. Visible cough impulse is seen. Urethral meatus is normal. External genitalia. Scrotum appears normal. Yes, sir.
Yes. Okay. What are the implications of each of this? Skin over the swelling appears normal. We'll take it, right? Okay. No questions on that.
In case of stagulation, it may be reddening. Redness can be seen. And if the patient is wearing truss before, it can be brown pigmentation over this region can be seen.
So redness sign of inflammation is an underlying strangulated bowel, you should suspect. And pressure marks, like you said, truss. Nobody is using those trusses nowadays, but even then you should know. Okay, right.
Yes.
So the next one is very important. No visible pulsations and peristalsis. In case
the skin is so thin, we can be able to see the peristalsis. If bowel is the content of the sac.
Very good. What is a other thing which can mimic peristalsis? You said it is extending from where to where?
From anterior superior iliac spine, 9 centimeters from anterior superior iliac spine to the bottom of the scrotum.
Okay. So any other movement in that area can mimic peristalsis, though it is not peristalsis. Okay. If you know, you can tell. Otherwise, anybody knows can text. Many people mistake this for peristalsis. What will happen if you just scratch the inner thigh with a small pencil tip or a pen tip?
Operation.
It's called cremastic reflex. Okay. Yes, we are not given a stone. Cremastic reflex. So the young surgeons or the beginning doctors will mistake sometimes the cremastic reflex for peristalsis. Okay. So
Yes, sir.
for that, the peristalsis will always be proximal to distal. Okay, so it will start from the mid-inguinal region and come to the bottom of the scrotum, whereas cremastic reflex will go from below up. That's how the cremaster contracts, you know. So one thing which you will have to differentiate from peristalsis is the cremastic reflex. Very good. Okay. Visible cough impulse seen. Nice. So I would add one small mistake error or which our students commit is telling expansile cough impulse in a inspection. Okay.
Inspection.
During inspection, as you rightly told, it should be impulse on cough or visible cough impulse seen is the correct terminology you should use. Right? You should not, in inspection, you should not tell expansile. Expansile cough impulse is a palpatory finding. Once you put your hand and as the patient to cough, it expands. It is called expansile cough impulse. In conversely, when you don't touch the patient and ask the patient to cough and it becomes bigger in size, that is called impulse on cough or visible cough impulse. Very good. So in inspection, do not mention expansile cough impulse. Kindly make a note of it. Right?
Yes.
Okay.
Yes, sir.
External genitalia.
Genitalia, scrotum appears normal, rugosity is present. Penis appears to be pushed to the left side. Inspection in supine position. Swelling does not disappear. Left groin is normal. No swelling is seen.
Yes. One thing you will have to mention here, which you are not mentioned, I will tell. Just previous slide. Scrotum appears normal, rugosity is present, you know. There, the visibility of testis you should tell. Why is it important? Testis is visible, separately visible or not, you should mention always. Okay, in a venous scrotal hernia. Why is it important? Where is testis visible? Where it is not visible? Kavya is saying undescended testis. Okay. Hydrocele, yeah. Undescended testis, it will not be seen obviously. In hydrocele also, it will not be seen. In hernia, the patient having a no undescended, normal testicular thing is there, but the testis is visible or not. What is the type of hernia? You tell me. What is complete hernia?
Complete hernia means going up to the bottom of the scrotum.
Okay. There, what happens to the testis?
Testis will not be seen separately.
Where will it be? It will be pushed posteriorly, right? The descending hernia will come, bulge and make the testis go posteriorly, so it will not be separately seen. That's what I want you to mention on inspection when you tell. You should tell, you have correctly told, scrotum appears normal, rugosity is present. The testis cannot be seen separately, you should write in this case. Okay? In a case of complete inguinal hernia, the testis will not be separately seen. Whereas in a incomplete hernia, where the distal most part of the hernia ends in the mid-scrotum level itself, the testis will be seen separately. Okay? So, if you are presenting a case of complete hernia, you should tell, and
Yes,
make
this
sure,
is-
inspect and confirm that the testis is not separately seen. If it is an incomplete hernia, the testis will be another prominent seen separately there. You should mention it always. Am I clear? Okay.
Yes, sir.
Go on. Yes. Next slide.
Palpation, not warm, not tender. Inspectory findings
Yes.
of size, shape, and extent of the swelling was confirmed. The extent is
Okay.
9 centimeters from anterosuperior iliac spine and 1 centimeter from pubic tubercle.
Yes.
Axil cause pimples is felt, cannot get above the swelling. Consistency is soft, elastic. Swelling is reducible manually with initial difficulty and reduces with drubbing sound.
Okay. So this expand cell cough pimples, I hope all of you know how to elicit it. So now we are not having any patient to examine at this stage, but once the college starts, you can come out to the ward and examine some patients. Okay, to make the patients
Yes, sir.
stand in a position and put your finger at the root of the scrotum where the prominence of the hernia is there, like that. Okay, you catch it like this. Thumb on the front side and 3 fingers at the posteriorly. In between the hernia should be there. Okay, root of scrotum area where the prominence, and press it and ask the patient to cough and elicit like that. Right? So expand cell cough impulse. Cannot get above the swelling. Okay. Right. So this is the one of the cardinal signs of hernia, inguinal scrotal hernia especially. So if it is occupying the scrotum also, you try to go above it. You cannot go above it. It is a hernia. If you can get above the swelling and your examining fingers are able to approximate each other, then it is hydrocele. Okay.
Scrotal swelling.
Right. Here I would ask you not to mention get above the swelling in a case of bibonocele or scrotal component இல்லாத herniaவுக்கு get above the swelling சொல்லக்கூடாது. Okay. Extent of swelling வந்து root of scrotum வரைக்கும் தான் வருது அப்படின்னா there is no point in telling get above the swelling. So you should tell it only in a inguinal scrotal hernia where scrotal component is obviously present. Very good. Okay. Whatever consistency can be there, this soft and elastic suggests what is the content?
Intestine as content, downy in case of omentocele.
Yes. So there are mainly 2 contents only. One is omentum, the other one is bowel. The bowel can be small intestine or large intestine, anything. So if it is a bowel, you will have that elastic consistency and soft. Whereas if it is a omentum, it will be doughy, right? So
And grand.
yes, in a chronically presenting hernia, initial part of the omentum, it will be doughy. It has been there for some time, chronically present. The omentum will get inflamed and attain a granular consistency. So there's a difference between the two. Early omentocele, the patient will give or exhibit doughy consistency, whereas a chronically contained omentum will exhibit a granular consistency. Or not? Okay. Okay. Right. Yes.
Next slide.
Last sentence you didn't read. It is reducible.
Swelling is reducible manually with initial difficulty and reduces with grubbing sound.
Okay. So the reduction also is important. There are 2 types of reductions. Omentocele, how it reduces?
Omentocele, first it goes easily and then there is difficulty
Yes.
in the last part. For intestine, first there is a difficulty due to then after the air pushed in, the later part will be easy to push in.
So the momentum will be first part will reduce easily, last part difficult because of what is the reason?
Fat in the initial part and fragile.
No, anybody can text. Why a momentum If it is a content of the hernia, initially it is easily reducible. Yes, Kavya is correct. Because of additions, right? Momentum gets easily adherent to the sac fundus or side wall of the sac. So it is because of the adhesive nature of momentum. Momentum is more prone for adhesion compared to bowel. Because of adhesions, the early part goes in easily. The late part, which is adherent to the sac, will not be easily reducible. Right? Are you clear? It is additions. Right? Then why does a bowel exhibit the converse finding? Like initially it is difficult, last part is easy.
Because initial part you have to push every air and fluid is present in the bowel, then the later part will be easier to push.
Okay. So there are also two reasons for that. One is the enterocoel has air as content. So initially when you push, only the air goes. Then the emptied bowels as a whole get reduced, number one. Number two is because of overcrowding. In a momentum, it is not a pipe-like thing, it comes and occupies the sac. Whereas a bowel, loop by loop, it goes and gets overcrowded. So when you try to push, the whole of bowel loops will compete to go into the neck of the sac. So one by one, the crowding is decongested, then suddenly the rest of it get reduced. Okay. So there are two reasons for the early difficulty and late easiness of reduction of an enterocoel. Number one is because of air being content. Number two is overcrowding due to the loop nature of the bowel, which is not present in a momentum. Okay, very good. Okay, special tests.
Ring occlusion test. After reducing the swelling, the patient in standing position, the deep ring is occulted with the left thumb. The swelling does not appear on coughing.
Good. How will you locate the deep ring, ma? Just tell me, and for sake of everybody. The standard question which might be asked in the yes.
1.25 centimeter above the midinguinal point.
Yes. What is the midinguinal point?
Which is between the anterior superior iliac spine and the pubic symphysis.
Very good. Okay. So, what are the fallacies of ring occlusion? This does not appear, What is the...
if it appears, it can be direct hernia.
Very good. In indirect hernia, it does not appear. It appears. So, why does it appear after occluding the deep ring? It comes in through what structure?
Indirect hernia comes through deep ring, inguinal canal, superficial ring, whereas direct hernia directly comes through the superficial ring without entering the deep inguinal.
Anatomical triangle it comes. That's what you should mention. Hasselbeck's triangle. So without asking, you should tell that. Okay. So a direct hernia protrudes through the Hasselbeck's triangle and comes to the superficial ring. What are the boundaries of Hasselbeck's triangle?
Medially by the lateral border of the rectus abdominis, laterally by the inferior epigastric artery, and inferiorly by the inguinal ligament.
Excellent. Very good. Okay. So deep ring occlusion test, you should all remember. There are also some associated questions with that. If you do well, the examiners may ask you, what are the fallacies or exceptions for DRO?
Sorry, exceptions for?
DRO test. You say on occlusion, if it does not appear, it is a indirect ring. Indirect hernia, right?
Yes, sir.
Even after occluding, an indirect hernia may appear. That is called an exception or fallacy of a test. The usual thing, fallacy. The indirect hernia still can appear after occlusion. What are the fallacies of deep ring occlusion test? What other hernia? It is not reliable.
Pantaloons hernia.
Good, very good. So pantaloon hernia will still occur. There is an indirect component, but there is also a direct component as well. The fallacies of test are: one is pantaloon hernia.
White
The other one,
deep ring.
very
White deep ring.
backless. Yes, very backless deep ring. பெருசா இருக்கும், இவ்வளவு பெருசா இருக்கும். ஒரு விரல வச்சு நீ அழுத்தினா கூட அதை ஃபுல்லா அதை பிளாக் பண்ண முடியாது. So you should remember, students. Yes, Kavya has told wide deep ring. Very good. There are two conditions which can be fallacious, okay, or exceptions, or not reliable. One is pantaloon hernia. The other one is patulous deep ring. Okay, right. Siemens.
Siemens technique. After reducing the swelling, the patient in standing position, right index finger is placed over the right deep ring, middle finger over the superficial ring, and ring finger over the saphenous opening, and the patient is asked to walk. Impulse is felt on the index finger on pausing.
Okay. Right, ma. Next slide.
Next. Invagination test. After reducing the contact, patient in recumbent position, fold of scrotum invaginated into the right external ring using right little finger. Impulse is felt on the tip of the finger. Direction of finger is upwards, backwards, and outwards.
Sir, you have told right little finger, but in your diagram it is right index finger. Is it all right?
Yes, sir. I could not get that properly.
It's not essentially little finger. Why you tell that is the finger should be as thin or small as possible. That's why they are mentioning. Okay, not necessarily your little finger. Any finger which is puny or little can be used. No problem. Okay. So how will the impulse be felt in various types of hernia here? In your case, yes, in your case, it is the tip of the finger, right? So, what is the interpretation?
It is indirect hernia. Whereas in case the impulse is felt in the pulp of the finger, it is direct hernia.
Yes. So, when you put your finger and face, you should keep the finger with palmar aspect facing downwards, right? So, if the impulse comes and hits the tip, it is indirect, because indirect finger is called otherwise oblique hernia. It goes through various gates. First ஒரு gate வரும், அப்புறம் ஒரு corridor வரும், அப்புறம் இன்னொரு gate வரும். Right? That is the deep ring, canal, and superficial ring. So that is called oblique hernia or indirect hernia. So it comes and hits you directly. I mean, at the tip. Whereas the direct hernia comes from posteriorly through the Hasselbacks. He comes from the back door, right? So it hits at the pulp of the finger. Very good. Next one.
Next slide. Percussion, resonant note is heard on percussion over the swelling. Auscultation, normal vowel sounds are heard. Vowel sound heard over the swelling.
Okay. One second, ma. It is 4:22, right? So, in this class, I have made some more discussions in the history and examination findings. We have made some what examination-oriented questions may be posed to you. Okay. Now we will brush up and finish the treatment up in the given time. In subsequent discussions of hernia, we'll post more on the treatment complications, right? So we'll make it fast now. You do it. Yes.
Examination of the left inguinal region is normal. Examination of the regional lymph nodes not enlarged. Examination of the testis, scrotum, and the penis is normal. Next slide.
Very good. So here I would like to remind you, in surgical presentation, examination of regional lymph nodes is very important. When you are given to examine a swelling or an ulcer, except some conditions like varicose vein, there even if it is infected, you will have to look for lymph nodes. Okay, examination of regional lymph nodes is a very, very important content of surgical presentation. You should all remember. Okay, right.
Yes.
Yes. Can you give your provisional summarization and provisional diagnosis?
Can I read it, sir? Examination of abdomen.
Yeah. Is there anything to tell? Yeah.
No, sir. No
What?
no significant findings, sir.
What is malgagnous bulge?
It is bilateral longitudinal bulge in the lower abdomen.
Suggestive of? What does that suggest?
Suggest there is reduce the tone of the abdominal wall.
What should you do for that? You should choose the correct method of surgery. Namely, you should invariably use a mesh only. No tissue repair should be done for a patient with malgagnous bulge. All of you understand? So malgagnous bulge is indicative of extreme abdominal muscle weakness or tissue weakness, in which if you do a repair, the patient will go in for recurrence. So malgagnous bulge irundale compulsorily you should use a plastic. No tissue repair should be done. That is the implication of malgagnous bulge. Okay, right. Next slide.
Systemic examination of the respiratory system.
Nothing is
No
contributory. You can move on to the
significant,
next. Yeah, next slide.
Diagnosis: right-sided, reducible, indirect, complete inguinal hernia with bowel as content without any complications. And European Hernia Society classification PL2.
Okay. So here, the reason for diagnosing all these things we have discussed during our discussion itself. Okay. So I'll ask you only one question regarding the diagnosis. What is the most important cardinal finding in this swelling you would put to say that it is a hernia? Cardinal sign or the most important sign of all your findings to tell that it is a hernia? இது இருந்தாதான் ஹெர்னியான்றது ஒரு கார்டினல் சைன்ன்றது பேர். ஓகே, கார்டினல் சைன் மீன்ஸ் the most important or representative sign. Yes. What is the most important cardinal feature of a hernia? Sign. நிறைய இருக்குன்றியா? You got many, is it? It is expansile cough impulse. That is the most important cardinal sign of a hernia. Right? எதை வச்சு first and foremost எதை வச்சு நீ hernia சொல்ற அப்படின்னு கேட்டா you should tell, sir, there is expansile cough impulse. So that's the first cardinal feature by which I would say that it's a hernia. You should answer. Okay? Right? இது hydrocele கேட்டனா get above the swelling சொல்லணும். அதுதான் most cardinal feature. Others can vary. Right? Yeah, hydrocele may be transluminant, may not be transluminant. A very tense hydrocele may not exhibit fluctuation. These are variables. But getting above the swelling is the cardinal feature of hydrocele. Like that, for hernia, the cardinal feature is expansile cough. Okay, right. So, investigations come.
Investigations. Next slide.
Okay, the question at this stage would be, what will you do for the patient? They will ask you. You should say immediately, you should not go for treatment. You should tell, I would like to investigate the patient, sir. Okay.
Yes.
Management consists of two parts: investigation, treatment. First, you should tell investigations. Let's go to the specific investigations. Anything is there? Yes.
USG abdomen and pelvis.
What will you look for in USG abdomen in this case?
Actually, USD doesn't diagnose hernia, but it rules out other conditions.
Very good. So intra-abdominal tumors, ascites, இதெல்லாம் பண்ணலாம். But age-wise, in particular age, is it useful in any other way? In a specific age group, has used the abdomen has got any other role? Okay, elderly, very elderly patients. No, I should have answered by now. Kavya is telling BPH. Is it possible? Very, very important. USG, in fact, has got only one condition where it can be useful in a case of hernia. Okay? An elderly person with hernia, the USG can diagnose benign hypertrophy of prostate. And as Kavya has rightly texted, it is the post-voidal residual urine. Right? So, what will you see in ultrasonogram of the abdomen? If they ask you, you should tell, I'll make out prostatomegaly, sir. Number one, you should tell. Okay?
Yes.
Are you there? Am I audible?
Yes, sir.
Okay. Then next one, you should tell, I look for post-voidal residual urine. What is post-voidal residual urine? How much is significant? So, patient வந்த உடனே full bladder சொல்லி பார்ப்போம் இல்லையா? You visualize the prostate. It will be full bladder. Then you ask the patient to go to restroom, empty the bladder and come back and again do a ultrasonogram. You should see whether the bladder is empty or some residual urine is there. Okay.
Yes.
Any residual urine of 100 ml or more, some people say 60 ml or more. So our urine போயிட்டு வந்த பிறகு 60 ml மேல residual urine இருந்தாலே it is suggestive of benign hypertrophy of prostate. Okay, Kartika?
Yes. Yes, sir.
Right. The questionnaire is not tell. USG abdomen in hernia has got only one specific indication to diagnose benign hypertrophy of prostate in an elderly patient. That is the first answer you should tell. What are the findings they ask you? We'll see we'll diagnose the prostatic enlargement or prostatomegaly. In terms of volume and weight also sometimes some people will say. Some sonologists will tell the size, anatomically it is enlarged. Some sonologists will tell grams. In weight also they can tell. Anyhow, both are suggestive of or diagnostic of prostatomegaly, number one. Number two is estimation of post-voidal residual urine. This terminology you should always remember. Kavya has correctly text like that. Post-voidal residual. Any post-voidal residual urine above 100 ml you can take. Some people say 60 ml. You can take 100 ml. 100 ml above is suggestive of benign hypertrophy of prostate. That is the only specific test you need to do for hernia. Otherwise, inguinal hernia is a clinical diagnosis. You don't need any other test to diagnose hernia as such. Karthika has rightly told. It is not diagnostic of the disease, but you will have to do it for visualizing the prostatic pathology. Right? Okay, ma. Next slide, ma.
Treatment lichen stents tension-free mesh hernioplasty on right inguinal region.
Very good. How will you do the surgery, ma? I told you 5 Roman letters. Did I tell you a batch or not? Right. So for any surgery, if they ask you, you will have a bit of hesitation to which one to put before like that. So I always ask my students to give 5 Romans for any surgery. Right. First one is getting the patient anesthetically fit. So you should tell, first I will make the patient anesthetically fit, sir. Okay. Second one is what type of anesthesia you will use this for this. Then third one is what is the position of the patient for surgery. Fourth one is under aseptic precautions. Fifth one is incision. Right? Roman 1, 2, 3, 4, 5. You write. For this patient, I will tell you how to answer. So I will get the patient anesthetically fit. and under spinal anesthesia with the patient in supine position under all aseptic precautions, I will make a right inguinal incision up to this issue there. Okay?
Yes, sir. Yes, sir.
For all surgeries, it may differ. We should change it for each surgery. For example, a thyroid is வேற மாதிரி சொல்லணும். Okay, I'll get the patient anesthetically fit and under the endotracheal general anesthesia with the patient in supine position, hyperactive neck. I'll make a low parallel incision. அது மாதிரி சொல்லணும். So kindly remember, have a standard method of telling how you prepare the patient for surgery, how you proceed on. That's the way. Okay, right.
Yes, sir.
Any other choice of surgery for this patient is there? Any minimal
In this patient,
investment?
we can use laparoscopic surgeries.
Very good.
Step and time.
It has become non-avoidable or it is an essential feature of surgery now. You can also opt for laparoscopic hernioplasty, hernia repair, if expertise and instruments are available and you are expertise in that field. You can also do a laparoscopic surgery, right? Okay.
Yes, sir.
So in the next classes, we will concentrate upon each one, types of surgeries, complications, and other things. We will investigations also. So before finishing this, I will just ask you, what are the other treatments available for hernia in all age groups? You said it is a hernioplasty, right?
Yes, sir.
Like instance, tension-free mesh hernioplasty is a type of hernioplasty, right?
For children, it is herniatomy alone.
Very good. Even Kavya has told it could either be herniatomy. Second one, Janani has told it is hernia raphe. Yes.
Hernia in case of emergency conditions where you can't keep a mesh or in
Yes.
septic conditions, strangulated hernia conditions, you have to go for hernia raphe. In
Good.
elective procedures, we go for hernioplasty, where we keep a
Excellent.
mesh and posterior.
So the surgeries for hernia overall there are 3 types. One is herniatomy. Second one is hernia raphe. Third one is hernioplasty. Herniatomy is for pediatric age group and also very young adults with small hernia, like a boy with some 16 or 18 years old small children with small hernia. Herniatomy is enough because the tissue is going to grow further and it is possible to grow without any defect. But in elderly people, once they have crossed the adolescent period, that tissue growth comes to a stop. So it does not grow further. So you cannot stop with herniatomy. You will have to do some strengthening procedure, namely hernia raphe. Karthik has correctly told that there are the few conditions where hernia raphe is done. One is contraindication for mesh allergies level இருக்கும் அல்லது infected field where emergency hernia you cannot keep a mesh for fear of infection. There you do a hernia raphe. And also in a younger age group with the possible not entered reproductive life, there is a bit of hesitancy in keeping mesh because of risk of cord adherence to the mesh. So they do hernia raphe. That is a small group of individuals. For all others, it is hernioplasty, right? So I usually, what is the difference between all these procedures? They ask you. I usually teach my students, each one has one R. Okay? Herniatomy is resection of the sac. So you identify, cut the sac and leave. Whereas hernia raphe is repair of the posterior wall. Whereas hernioplasty is reconstruction using a prosthesis or foreign material. So one R for each. You remember, herniatomy is resection. Hernia raphe is repair. Whereas hernioplasty is reconstruct the posterior wall using mesh. Right? So take one R for each. So I think we'll wind up. next time அடுத்தவங்க யாராவது hernia present பண்ணும்போது we will concentrate more on various types of surgeries and complications of surgeries, some anatomy, physiology also. I will strategically start discussing in those classes. Right, ma? Thank
Yes,
you.
sir.
Thank you, everybody.
Thank you for the class.
Yes, ma. So 9:30 we will join. Okay.
Yes, sir.
We are discussing.
9:30 multi-module.
Yes, I will be there. You give a link.
Yes.
We will start. Anybody
Yes,
a quick any doubt? You can just tell. There's not much of time. If you have any doubt, I will wait for 2 minutes. Okay. Thank you. We have got more classes to come. Your doubts can be clarified there. Apart from doubts, I want all of you to get the feel of presenting and be confident. That's why I wanted you to choose this opportunity and utilize that. Each of you should present, because most of the time observing a person present may be easy, but when you start presenting, there are some hiccups, some difficulties which are easily thrown away once you start presenting. I want you to all of you to gain confidence by taking turns and presenting nicely. Okay, bye. We'll meet at 9:30.
Thank you.
Thanks, everybody. Thank you.
Thank you, sir.